A very good evening to all of you. On behalf of Andhra Pradesh Ophthalmic Society, we again welcome you to this Oculoplasty online course, webinar series 3. So last week, sir had covered ptosis, an overview, and this week, sir will be covering the evaluation and management part of ptosis. And we welcome sir once again and also thank him on behalf of the society for sparing his valuable time every Tuesday and preparing these wonderful lectures and educating all our members. Thank you, sir. Please go ahead with your presentations.
Thank you, Madhu. So this week I'll be concentrating on evaluation and management of ptosis. Last week we were talking about different types of ptosis, the classification, something about each type of ptosis that is clinically important and relevant. So today we'll be talking about the evaluation management. Some slides will be overlapping, sharing with the previous ones, but I thought that I did not want to change them because seeing them twice will probably give more impact than seeing them once. For that reason, I am continuing with some of the slides that will be there. It's not moving. 1 minute.
Yeah, screen share in the.
Okay. Okay. First, starting with the history, we would like to know whether the ptosis is congenital or acquired. Why should you know that? For two reasons. Number one, timing of the surgery. Congenital ptosis, normally we prefer to do surgery as after the age of 4 years, when the patient comes, because it is a stable in type and it doesn't change over period of time. We normally wait for the age of 4 years because we normally wait up to the age of 4 to 5 years because it is easier to evaluate the child at that age. It is very difficult to evaluate the child before the age of 4 or 5 years. For that reason, normally we say that the timing of surgery for congenital ptosis is about 4 or 5 years. But here there's a small catch, which we came to know as we were growing with the oculoplastics and ptosis. In case of congenital ptosis, nearly 30 to 40% are associated with amblyopia. And we did a study for the dissertation of one of my postgraduates, and we found that nearly 38% had amblyopia in congenital ptosis. And the chief factor for amblyopia is anisometropic, myopic astigmatism. So if a child is brought to you with about 6 months of age, or an infant is brought about 1 year or 6 months, I prefer you do a refraction, cycloplegic refraction, to see whether this child is developing anisometropic astigmatic error. If it were so, we prefer to do surgery then itself at the age of 6 months or 1 year itself to prevent amblyopia. Otherwise, we'll be following the child once in 6 months or once in a year up to the age of 4 years. Every visit, we are doing the cycloplegic refraction. And then, once the astigmatism is developing, we'll go ahead with the surgery. Or if there is no astigmatism, we'll wait up to the age of 4 to 5 years. And when we can confidently and very well evaluate the child, then we decide about the plan of surgery and do the surgery. Whereas acquired ptosis can fluctuate with time. For example, a neurogenic ptosis, because of diabetes, may recover spontaneously to some extent or completely sometimes. So the timing of surgery varies in acquired ptosis, where we would like to follow the patient for at least 3 months stable ptosis and then do surgery. That's about the timing of surgery. Planning for surgery. Undercorrection is the most common complication after surgery in congenital ptosis, and overcorrection is the most common complication of surgery in acquired ptosis. So when I'm doing surgery for ptosis, if the LPS action is less, I prefer to do a little overcorrection rather than undercorrection. Similarly, if it is an acquired ptosis, I don't mind a 1 millimeter of undercorrection on the table rather than 1 millimeter of overcorrection on the table, because it's going to get worse over the period of time. So for the planning of surgery also, we would like to know whether it is an acquired ptosis or a congenital ptosis. How to know? It's lid lag on down gaze. Here is a child with congenital ptosis left eye with a lid lag on down gaze. It's a congenital ptosis. This young lady has ptosis on the left eye, which is worse on down gaze. It's an acquired ptosis. A bilateral ptosis for this young man. On looking down, you can see that the palpebral aperture is so narrow, almost as if he has shut the eyes. It's an acquired ptosis. Similarly, a elderly lady with asymmetrical ptosis, more in the left eye. On looking down, the width of the palpebral aperture has become narrow too much. That is under an acquired ptosis. So a lid lag on down gaze is in favor of congenital ptosis, whereas no lid lag and worsening of the or narrowing of the palpebral aperture or worsening of the ptosis on down gaze is points towards acquired ptosis, except if it were a trauma and there is a fibrosis and scar in that lid that has ptosis. Why this happens? So again, for another postgraduate, we did the histopathological changes of levator palpebrae superioris in congenital and acquired ptosis, where we did the levator excision. Here in this patient, in this slide, you can see that there are lots of muscle fibers in the LPS, but some of the muscle is replaced with fibrovascular tissue. Whereas in this slide, in the congenital ptosis, there are very few muscle fibers seen. Mostly it is fibrovascular tissue. And here, this is an acquired ptosis where the muscle fibers are normal, but there is a lot of fatty infiltration. A bit of fatty infiltration you can see in the muscle LPS in congenital ptosis also. So in congenital ptosis, the muscle fibers are replaced by fibrovascular tissue. The more the fibrovascular tissue, the less is the levator function and the more is the lid lag on down gauge. Whereas in acquired ptosis, there is fatty infiltration, there is no fibrovascular tissue, and also the attachment of the LPS to the tarsus has receded, and that's why there is a ptosis, and the ptosis gets worse when the levator relaxes in the down gaze. So this histopathology explains why the lid the down gaze has a lid lag in congenital ptosis and worsening of ptosis with further narrowing of palpebral aperture in acquired ptosis. After that, we would like to know how is the onset, especially in acquired ptosis, whether it is acute, as in a case of a trauma, or a neurogenic ptosis like a diabetic or hypertensive causing a neurogenic ptosis, subacute, as in case of a cysticercosis and inflammations and swellings which lead to mechanical ptosis, or whether it is chronic, as in case of a involutional ptosis. Progression, whether it is stationary, as it is in case of congenital ptosis, whether it is slowly progressive, as in case of an involutional ptosis, whether there is a spontaneous recovery and it is improving by itself, which occurs in, as I said already, in diabetic, and even sometimes in myasthenia, the ptosis can be fleeting. I have come across few people who said that I have ptosis 2 years back. It has become normal by itself over a period of 6 months. And since again 1 month, I am having ptosis. It's a very recently I have seen a patient only last week with this history. And it's proved to be a case of myasthenia gravis. And it could be intermittent, as in case of cysticercosis, or again in case of myasthenia. We would like to know whether there are diurnal variations, which are typically seen in case of myasthenia gravis. And also in involutional ptosis, there will be diurnal variations. As the patient sleeps in the night, when the patient wakes up, since the LPS has got enough rest, there won't be a ptosis, or the ptosis will be very minimal. As you see this girl in the left eye, there is no ptosis. But in the evening, because of the fatigue phenomenon, the ptosis gets worse. Similarly, in involutional ptosis, since the LPS has minimal hold on the tarsus, in the morning it is able to pull the lid up and so that there is no ptosis. But as the time progresses, since its hold on the tarsus is less, slowly the lid droops and there could be diurnal variations. You would like to know the vision for few reasons. Number one, whether it's a case of a congenital ptosis, whether there is any amblyopia. And if it's a child, you have to treat the amblyopia. For that reason, you would like to know whether the visual acuity of the child. Number two, you would like to know whether the patient is a contact lens wearer, because contact lens wearers, some of them are prone to develop myogenic ptosis. A type of aponeurotic ptosis can occur in contact lens wearers. The other thing in vision is diplopia. Diplopia occurs in myasthenia gravis and neurogenic ptosis, especially due to Turner palsy. You would also like to know test for the field of vision, because you would like to know whether the surgery is functional or whether the surgery is for cosmetic purposes. As you are aware, if there is a severe ptosis obstructing the pupil, as you can keep your hand in front of your eye, the visual field in the upper half can be lost. So if you correct the ptosis, that's what you can do is you take the visual fields, record the visual fields with the eyelid in the ptotic position, then apply a tape and lift the lid to the normal position as if the ptosis has been corrected, and again repeat the visual fields. If there is a significant change in the visual fields, significant improvement in the visual fields in the upper field, the surgery becomes functional and it is covered by insurance. If there is no significant improvement in the visual fields, the surgery becomes cosmetic and may not be covered by the insurance, especially abroad. Amblyopia in congenital ptosis, as I said, we did a dissertation for a postgraduate. The total sample size was 138 patients. And the incidence of amblyopia was 38.2% of them. It's a very significant number have amblyopia. And incidence of non-amblyopia is 61.7%. When we look into various factors that can lead to amblyopia, we look into the poor levator function, strabismus, significant refractive error, pupillary occlusion, compensatory head posture, and Herring's reflex presence. We found that and made a statistical analysis. We found that poor levator function is not significant statistically, though the more important is that strabismus and the significant refractive error, nearly 83%, are associated with significant refractive error, which caused amblyopia. Pupillary occlusion, amblyopia exanopsia, which is supposed to be the cause as per the textbooks, was not much because nearly 39.3% or 40% have pupillary occlusion in the non-amblyogenic people. So the most important things are poor LPS action, strabismus, and significant refractive error, and it is high myopic astigmatism with anisometropia that has caused amblyopia. In all types of congenital ptosis, the prevalence is the same. That means in simple congenital ptosis as well as different types of congenital complicated ptosis. You would like to know whether there is any history of trauma. Trauma per se, if there is an injury to LPS and is not detected during the repair, can cause ptosis. A Turner paralysis due to trauma can cause traumatic ptosis. And fractured orbits, if it is significant, can cause enophthalmos and can cause pseudotosis. Similarly, fractured orbits can be associated with trauma to the lid and can cause ptosis along with fracture, where both need to be attended to. And also another important thing is that trauma to the LPS due to the speculum that we apply for your intraocular surgeries or even extraocular surgeries, when they are very tight, may damage the LPS and can cause ptosis, which is luckily, fortunately, transient and recurs over a period of time, few months' time. But if it doesn't recover within 6 months to a year, we prefer to do surgery for that. The incidence is much less, but that is one thing you have to remember and probably explain as one of the complications of your cataract surgery as a rare complication of cataract surgery. We would like to know about the systemic diseases like diabetes, both for etiology like adaptic diurnal paralysis and for surgical considerations like adequate control of diabetes. Similarly, you would like to know whether the patient has a thyroid disease, and thyroid orbitopathy can cause ptosis, as you are aware, because of its association with myasthenia. Number two, because of compressive thyroid paralysis at the apex, and also because severe proptosis can stretch the LPS, stretch the lid, stretch the LPS, and can cause aponeurotic ptosis. At the same time, a good systemic control of thyroid disease is very important when there is not associated with thyroid orbitopathy also. If a patient has ptosis and systemic thyroid disease, that needs to be controlled well before the patient is taken up for surgery. Same with hypertension, both for etiology with a hypertensive, Diurnal palsy, and surgical consideration, a good control of hypertension, because lids as itself, they bleed badly, and hypertension worsens the bleeding. Myasthenia gravis, because you would like to refer the patient and not do surgery in case of myasthenia gravis, you prefer to refer the patient to a neurologist or a physician for the management of myasthenia. Similarly, you would like to know whether the patient has bleeding diathesis. If the patient has a bleeding diathesis, probably you take the help or opinion of a hematologist whether to go ahead with surgery or not because of the severe bleeding that can take place. Similarly, use of blood thinners, the patient has to stop them 3 days prior to and 3 days after surgery. And we have to go ahead with a good cautery mission to control bleeding intraoperatively. Always for every patient, you have to know whether there are any drug allergies. So history of known drug allergies, if history is positive, you mark the drugs to which the patient is allergic in a box, and so that it doesn't miss your attention. And also probably in the front of the case sheet with a red pen, you can mark that the patient is allergic to following drugs in a box, so that unknowingly, unwantedly, we don't prescribe the drugs to which the patient is allergic. So for every patient, make it a point to ask for history of known drug allergies, whatever is the case. It's not just ptosis. And you write NKDA if there are no drug allergies, no known drug allergies, and put it in a box so that you have done your part. You must be knowing the drugs to which the patient is allergic before you start the treatment. Family history of ptosis is typical in Blepharophimosis syndrome, where 90% of the patients give a autosomal dominant history. Here you can see two sets of patients where the father and the son have severe Blepharophimosis syndrome. Here the patient underwent surgery and now brought his son for with a Blepharophimosis syndrome for correction. And here the patient has not undergone surgery and he has also a convergent squint, and the child has been brought with Blepharophimosis syndrome, and you can very well see the compensatory head posture with the chin being elevated. Congenital simple ptosis, I have seen very few families where this congenital simple ptosis has run in the families as autosomal dominant trait, but very, very few of them. In majority of cases of congenital simple ptosis, there is no family history of ptosis. Chronic progressive external ophthalmoplegia also can run, as we have talked in the previous lecture, as either autosomal recessive more commonly or rarely as autosomal dominant trait. In the evaluation, so we have covered what are the important factors that we have to take in the history. And then coming to the evaluation, the first thing we would like to know is head posture, whether there is any compensatory head posture. If the compensatory head posture is usually seen mostly in bilateral ptosis, where the ptosis is severe and the pupil is occluded. When the pupil is occluded bilaterally and the patient cannot see, the typical compensatory head posture is that the chin is up, then both the eyebrows go up and elevated, and when they are elevated, you may see creases on the forehead. This is the typical compensatory head posture, and in case of congenital ptosis, when the patient chin is up, the eyelids are coming down, and because of the fibrosis that is there histopathologically, there is a lid lag which widens the palpebral aperture in that position, and as the eyeballs roll down, the patient can see clearly. This is the typical compensatory head posture that you see in case of severe ptosis, especially bilateral ptosis, both in congenital as well as in acquired ptosis. Forehead wrinkles are because the brow position, the brow that is elevated. Looking at the brow position, the brows are usually, eyebrow is elevated because of extra action of the frontalis, which is an accessory elevator of the lid. As the frontalis contracts to elevate the upper eyelid, the eyebrows go up. You can see the typical eyebrow elevation, especially more so in the left eye for this child. In Aponeurotic senile ptosis, there's involutional ptosis, there could be brow ptosis as a senile change. Both you want to know, because when you are evaluating the ptosis with composite head posture and these compensatory changes, you have to evaluate with the taking care of the head posture, making it normal, and making sure that there is no elevated brow. You bring it down, ask the patient to relax the eyebrow, and then evaluate. A brow ptosis can accentuate dermatochalasis and can increase the ptosis by a millimeter or two. So in that situation, it is preferred to correct the brow ptosis, then correct the dermatochalasis if it is present, and along with the ptosis. So that is the preferred order of doing surgeries in the presence of brow ptosis. So that is the importance of knowing the brow position, because elevated brow reduces the ptosis and brow ptosis increases the blepharophimosis. Here you can see an elderly man with a typical chin elevation and composite head posture, as you can see here in the profile picture. Both the eyebrows are elevated. You can see, but since it is a case of acquired ptosis, where the palpebral aperture in down gaze is narrow, unlike in congenital ptosis where it is wider, in spite of this brow ptosis, the compensatory head posture and brow elevation, trying to bring the eyeballs down, he is not able to see very clearly. And what he says is that he elevates both the lids with his fingers so that he is able to see people like that. So this is what you may be able to see and make a note of it and document it when you are evaluating the patient. So when the brow ptosis is elevated, here you can see this elderly gentleman with elevated brows. Whereas here you are seeing an elderly gentleman with involutional ptosis, whereas here there is a severe brow ptosis with a dermatochalasis, as you can see next. This gets rid when you correct the brow ptosis. The dermatochalasis will be reduced. And then you can do the bilateral ptosis, blepharophimosis correction. So this is how you have to evaluate, and that is the importance of each, practical importance of each of these findings. Then you would like to know what is the amount of ptosis. There are two methods. The earlier method was what is proposed by Berk's method, where in the straight primary gaze, with the eyebrows in the normal position, you measure the distance, vertical distance in the center of the palpebral aperture from the lower lid to the upper lid with a transparent roller or an opaque roller that's comfortable. I prefer an opaque roller like this to a transparent roller. And compare it with the other eye or the normal. In case of bilateral ptosis, we compare it with the normal readings, that's 9 millimeters. And in a unilateral ptosis, we compare it with the other eye. Let's suppose the width of the ptotic eyelid, the width of the palpebral aperture, or the height of the palpebral aperture in the straight gaze in unilateral ptosis is 6 millimeters. The height of the palpebral aperture, the vertical height of the ptotic lid is 6 millimeters and normal is 9 millimeters. The amount of ptosis is 9 minus 6, that is 3 millimeters. That is the Burke's method. But this need not always be true, because when we are measuring the height of the palpebral aperture, which depends on the position of both the lower lid as well as the upper lid. If there is a difference, if the lower lid is not normal in position, let's suppose there is 2 millimeters of retraction of the lower lid and 3 millimeters of ptosis for the upper lid. So MRD1, which is normal is 4 millimeters, is 1 millimeter in this patient. MRD2, which is 5 millimeters, is 7 millimeters in this patient because of the lower retraction. If you do the Burke's method, the width of the palpebral aperture is 8 millimeters. When you compare with the normal reading of 9 millimeters, so the amount of ptosis as per Burke's method becomes 9 minus 8, which is 1 millimeter. But actually, he has 3 millimeters of ptosis. So that is inaccurate. That's why the margin reflex distance methods have come into vogue. We measure the amount of ptosis or the lid positions, both upper lid as well as the lower lid, by margin reflex distance, MRD, 1 and 2, 1 for the upper lid and 2 for the lower lid. What is margin? Lid margin that we are considering. What is reflex? The Purkinje image, the corneal light reflex. So when the patient is in the straight primary gaze, you keep a torch light, a source of light, at the same height as the eyeball and switch it on. You see the Purkinje's image on the corneal light reflex here. Corneal light reflex here. This is empty. So, I'm sorry, yeah. So, from here to the upper lid margin, so you make the scale leading to the lower part of the margin to the upper lid. Let's suppose its normal is 4 millimeters. This is MRD1. And from the lower margin of the light reflex to the lower lid is reflex 2. In this patient with this 113 mm at the lower border, it is 4 millimeters MRD1 and 5 millimeters MRD2. So we represent this as +4, +5 MRD1 and MRD2 in this side. In the example that I gave just now with Burke's method, where it can go wrong. So if the patient has 3 millimeters of ptosis, MRD1 will be 1 millimeter. And if the patient has 2 millimeters of lower lid retraction, MRD2 will be 7 millimeters. So how it will be represented? It will be represented as +1 millimeter and MRD2 as +7 millimeters. By looking at that reading, I am able to come to the conclusion that this patient has an upper lid ptosis of 3 millimeters and lower lid retraction of 2 millimeters. Whereas if I do Berg's method, it will be 8 millimeters, and I may be mistaking it for a case of 1 millimeter of ptosis. For this reason, we have to measure the amount of ptosis using margin reflex distance 1 and margin reflex distance 2 for each eye. And coming to the amount of ptosis, you have, especially in case of bilateral ptosis or a severe ptosis with pupillary obstruction, you have to look for Herring's reflex. That means, what is Herring's reflex? Both the yoke muscles get equal innervation for both the muscles. When there is a severe ptosis and the pupil is obstructed by the ptotic lid and the patient is not able to see, the brain recognizes this, and to elevate the ptotic lid, it sends extra innervational effort to the levator palpebrae superioris on the ptotic side. Because of the Herring's reflex, the same extra innervation goes to the LPS on the opposite side also. Suppose this patient has 4 millimeters of ptosis or 3 millimeters of minus 3, there's 7 millimeters or 8 millimeters of ptosis, and the pupil is obstructed. The other eye, there is 2 millimeters of ptosis in the left eye. So when you lift the lid and keep it elevated for 30 seconds to a minute, the brain realizes that the pupil is uncovered. There is no need for extra innervation, and so the extra innervation is shut off. When the extra innervation to the LPS is cut off to the ptotic lid, same thing happens to the other side also. So if that lid droops down, it means that that lid has ptosis. So in that position, you have to measure the MRD1 and D2, taking care of the Herring's reflex also, whenever you are doing MRD1 and D2 on both the sides. So here, if you look at this patient, this is the light reflex. Just in the previous slide, we have seen the normal, where the MRD1 is 4 millimeters. If you look at this patient had MRD1 just 1 millimeter or 1.5 millimeters plus, and there is a lower lid retraction of about 2 millimeters. So this will be plus 1 MRD1 plus 7 MRD2. That's how we represent this. When you come to this patient, if you observe carefully, you are seeing probably a small crescent of the light reflex. So the lid level is at the lower end of the light reflex mark. So MRD1 here is represented as 0. MRD2, if the lid position is normal, so MRD2 is 5 millimeters. In this patient, the light reflex is not seen at all. In this condition, what we do is we keep a scale here, coincide the reading with 0, and lift the upper lid gently till you are able to see the light reflex. How many millimeters you have to lift the lid up so that the light reflex is visible is marked as minus reading. In other words, if you have lifted the lid by 2 millimeters so that the light reflex is visible, you represent it as MRD1 minus 2 millimeters. So the amount of ptosis in the 3 examples or 3 figures or of 3 different patients is we are deducting the MRD1 of this patient from the normal value of 4. So in the first patient, where the MRD1 is 1 millimeter, the amount of ptosis is 4 minus plus 1, that is 3 millimeters. In the second patient, MRD1 is 0, the amount of ptosis is 4 minus 0, that is 4 millimeters. In the third patient, where the MRD1 is -2, the amount of ptosis is 4 minus -2. Minus becomes plus. So it is 4 plus 2 or 6 millimeters is the amount of ptosis. So depending on the amount of ptosis, the ptosis is classified as mild, moderate, and severe. Ptosis 2 millimeters or less is mild ptosis. Ptosis 4 millimeters or more is severe ptosis. In between, that is 2.5 to 3.5 millimeters of ptosis is moderate ptosis. So this is what I am talking about Herring's reflex. Here in this young lady, there is a severe ptosis. You are not able to see the light reflex. It is -2 millimeters of ptosis. And here you can see in the left eye, the eyelid is retracted. You are able to see the 12 o'clock limbus and probably about 0.5 millimeter of sclera also. When the ptotic lid is lifted up and the pupil is uncovered, the brain has realized that there is no obstruction to the pupil now. So the extra innervation is cut off. And what has happened? The retracted upper lid of the left eye has come to the normal position that you can see. Similarly, if the patient has mild, it's the normal position. If in the Herring's, it may be a mild ptosis. A mild ptosis can become a moderate to severe ptosis. So you have to look for Herring's reflex, and if it is positive, elevating the upper lid of the ptotic eye, you have to take the measurements of the other eye. Then you have to measure the width of the palpebral aperture in the 3 gazes: up gaze, straight gaze, and down gaze. Here is a case of an acquired ptosis where the width of the palpebral aperture on down gaze is less than that of the normal eye. Right. Then you have to measure the LPS function. This is very, very important. Here, how do you test the function of a muscle? Its action from the relaxed state to the maximum contracted state. That is the function of a muscle, how we test. So LPS is in the relaxed state when the patient looks down completely. And in the maximum effect or action is when the patient looks up, when the LPS is pulling the leg. But one instruction you have to give to the patient is, when you are doing this test, you should not move the head. When you ask the patient to look down, don't look downwards, moving the chin down. Look up, don't elevate the chin. So you demonstrate that you have to ask the patient to look straight, look down, and look up maximum without moving the head. That you have to inform the patient, and then you take the readings. So the same patient looking down, you make a scale something, you note the reading, and ask the patient to look up and take the reading, how much the lid has moved. In this case, it has moved by, is 140, probably about 8 to 9 millimeters. So the action of LPS is 9 millimeters. Repeat it 2 or 3 times till this. While you are doing this, the one important thing that you have to do is to elevate the action of the frontalis. You have to apply pressure over the eyebrow, pressing the brow and the frontalis against the bony rim. And then you have to ask the patient to look down, apply pressure, put the scale, ask the patient to look up, prevent the action of the brow. And when the patient looks up, take the reading. Repeat it twice or thrice. At least 2 readings should be the same. And that gives you the action of the levator palpebrae superioris muscle. The other things that you have to observe in the evaluation are MLD, or margin limbal distance. Ask the patient to look up again with the pressure over the eyebrow and measure the distance from the lower part of the limbus at 6 o'clock position to the lid margin. Normal is 9 millimeters. Here, let's suppose it is 1 millimeter. The difference between normal and this, that is 80 millimeters, multiplied by 3 gives the amount of levator that is to be resected. This is theoretically, yes, but practically with most of my colleagues with whom I spoke, they said that it's not true in every case. So we decide on it on the table what to do. How much amount of resection is to be done is decided on the table. Then lid lag on down gaze so that we know whether it is a congenital or acquired ptosis. Lagophthalmos is very important because most of the surgeries will give some amount of lagophthalmos, which is transient in levator resection, which requires over a period of time, whereas in frontalis slings, it could be permanent. If the patient has already lagophthalmos, we may be probably deciding at looking at the corneal health and other things, we may be deciding a little bit of undercorrection. Lash ptosis, if it is present, we will modify incisions so as to correct the lash ptosis also. And margin lid crease distance is very, very important. This is a single margin lid crease distance that you are seeing. This child has 3 margin lid crease distance, and this margin lid crease distance we prefer to match with that on the other side when I am doing the levator resection surgery or aponeurotic surgery. My incision is at the MLD of the normal eye so that the lid crease matches that of the normal eye. As for the lagophthalmos, always ask the patient to gently close the lid, not forcibly, because we would like to know whether there will be lagophthalmos post-surgery, especially during sleep, where there will not be forcible closure. So ask the patient to gently close the lid as in sleep. And here you can't see any lagophthalmos when you are looking straight. But when you are looking from down, this is the way you have to see. You can see that there is a lagophthalmos, both the lids a little more in the right when compared to the left. Right? So this is how you are looking from below to see whether the patient has any lagophthalmos. Here is the patient with the lash ptosis where the eyelashes are coming down. Normally, so as you are seeing here, this medial side, they are okay, but the lateral side, you can see the eyelashes are coming down. This is the normal. The eyelashes come down a little and then take a curve and go upwards. But if you are seeing them covering the sclera, it means that there is lash ptosis and this needs to be taken care. Ocular motility, we'll have to do the ocular motility by cover test. And that we have to, that's important in myasthenia, important in monocular elevation defect and all those conditions, neurogenic ptosis and all that. And look for the Bell's phenomenon. If the Bell's phenomenon is not satisfactory in case of monocular elevation defect, you have to do force reduction test. Whenever there is a motility restriction, we have to do a force reduction test so that we know whether the superior rectus is at fault or whether there is inferior rectus is tight and it is not allowing the motility restriction. And what we did depends on the FDT. And hypo, which is associated with the monocular elevation defect, can also cause pseudotosis. That is why you have to look for this Bell's phenomenon, FDT and pseudotosis. That is done with the cover test. And look for the synkinesis, Marcus-Gunn phenomenon, which may be very minimal as is in this child, which is just a couple of millimeters or less, where the child and parents are not aware. We have to look carefully for that and document and show the patient, demonstrate that to the parents in this child. Look at the corneal for the corneal sensations, whether there is an exposure, whether there is any fluorescent staining, superficial punctate keratopathy, because that can be there. And if it is there, we are looking for a corneal with a ptosis under correction rather than full correction, especially in involutional ptosis associated with dryness and involutional ptosis in elderly people. I don't mind doing corneal wetting, tear wetting, that is Schirmer's test. In Blepharophimosis, we look at the inner intercanthal distance, we look at the interpupillary distance, and we measure the width and height of the palpebral apertures. Then you have to do the fundus evaluation, especially for retinitis pigmentosa, especially in case of Kearns-Sayre syndrome, and look for papilledema, especially in case of neurogenic ptosis. Do a refractive errors, look for the refractive errors, do a cyclophysical refraction, especially for anisometropic astigmatism or unilateral high myopia, which may present as pseudotosis of the other eye if they think that this eye is normal, or which may present as a pseudoproptosis also sometimes if they look at this, the other eye being normal. It depends on which eye the patient thinks is normal. Similarly, look for any high refractive errors and the patient wearing any contact lenses, because that could be a cause of acquired myogenic ptosis. The clinical test that we do is look for the Cogan's twitch in case of Myasthenia gravis, where ask the patient to follow the light from the down gaze to the up gaze and suddenly stop. The lid goes up further up and comes down. That is called Cogan's twitch in Myasthenia. Do the ice pack test in case of Myasthenia. In acquired ptosis, do the drosin, put a drosin, and if the ptosis gets improved, you may think of muellerectomy as an alternative surgical procedure. Hydrophonium test can be done in case of Myasthenia, where the suspicion is very strong, but the ice pack test is unequivocal. We may be doing a hydrophonium test, but to be honest with you, ice pack test has almost replaced hydrophonium test. This is the ice pack test. So the patient with with acquired ptosis, bilateral, asymmetrical, and we put the ice pack. Of course, I have used a Sprite in my clinic, and post 2 minutes, the ptosis has improved. Patient with the bilateral ptosis, ice pack test. The patient with where I have used 2 Sprite bottles on either side, and after 2 minutes, the ptosis has improved both the sides. Fatigue test. Ask the patient to look at the torchlight or figure that is put up. So LPS is contracting for a period of 2 minutes and the lid has drooped down, ptosis has worsened. That is the fatigue test. Fleeting test. This is the patient with ptosis in the left eye. After some time presented with ptosis in the right eye, with the left eye being almost normal. This is the patient with hydrophonium test, where the ptosis has totally disappeared after hydrophonium test, pre and post hydrophonium. Hydrophonium injection is given by the anesthetist with the atropine injection by the side in the operation theater with all the emergency there, because there could be severe side effects. In case of Marcus-Gunn ptosis, association with monocular elevation defect is seen in nearly 50% of patients. So look for the synkinesis versus ptosis, and depending on that, we'll decide what to do. Whether synkinesis is more, we have to disinsert or I prefer to access the LPS rather than disinsertion and do a bilateral brow suspension. Here are the patient, and this is the patient with Marcus-Gunn ptosis. The young lady has hypo, as you can see here, with elevation defect. So this is the patient with Marcus-Gunn ptosis, significant amount of Marcus-Gunn ptosis with double elevator palsy associated with this. In case of Blepharophimosis syndrome, we would like to measure the telecanthus, that's the inner intercanthal distance, interpupillary distance, and horizontal width of the palpebral aperture and height of the palpebral aperture. And about 10% are sporadic cases, 90% give history of autosomal dominance. In case of aponeurotic ptosis, the clinical features are severe ptosis, as you can see here, with good levator function, high and multiple lid creases that you can see, a deep superior sulcus, thin lid because the LPS has gone up and retracted. Ptosis is worse on down gaze, as you see here, almost the lid is closed. The other lid also, which has mild ptosis, shows a very narrow palpebral aperture. And this can lead to difficulty in reading. Sometimes the aperture may be shut off so that when you keep the book down, the eyelids are closed when you are trying to look down, and he is not able to see anything, and lid can cause difficulty in reading and difficulty in ear work. May have diurnal variations with worsening towards the end of the day. And hearings can be positive. As you see the patient here it is normal, fairly normal, but on elevating the lid of the severe ptosis, this also has a severe ptosis. This lid also. It could be associated with senile changes, like as you see in this patient, an ectropion horizontal laxity and an ectropion, and a minimal ectropion on the other side also can have a cataract and other things. Myasthenia, bilateral, and ice pack test is positive. And CPO, bilateral ptosis with motility restriction, ice pack test is negative. Turner palsy, we have discussed the clinical ptosis, usually unilateral ptosis. On elevating, eye is deviated and out because of the unopposed action of the lateral rectus. Ocular motility problems can lead to diplopia. Pupillary involvement you have to look for. Spontaneous recovery may occur if it is because of diabetes, in which usually the pupil is not involved. If the pupil is dilated, look for a CT scan. Here you can see that there is severe ptosis patient with motility restriction in all gazes, and the left eye is totally abducted and is not moving up, not moving down, no adduction, it's totally abducted. Pupil is dilated. So that can also happen sometimes, rarely, in case of superior ophthalmic vein thrombosis. This patient, again with a severe ptosis with abduction and motility restriction because of a suprasellar meningioma. So I think we have completed 1 hour. Just I'm wondering whether we can take the planning of treatment at the next class, or it may take under 15 or 20 minutes. Shall I continue, Madhu?
Yes, sir. You can continue, sir.
Okay, I will continue with planning of treatment. The things are whether it's medical versus surgical. That's
okay, sir.
And
okay.
The second thing is crutch spectacles. The third option is surgery, and what are the contraindications for surgery. These are the things that we have to discuss. Medical treatment is in myasthenia and in myocystic. Here you can see a patient with minimal ptosis with cysticercosis involving the LPS-SR complex in the CT scan. Patient has been treated with albendazole at a dose of 15 milligrams per kg body weight in 2 divided doses per day, with prednisone 1 milligram per kg body weight in single dose over a period of 4 weeks. The treatment has been tapered and patient has improved within 2 weeks. Same case of myocystic with severe inflammatory syndrome with motility restriction, CT scan showing a hugely enlarged LPS-SR complex with the cyst and the scolex. Patient put on albendazole with 2 divided doses plus prednisolone at a dose of 2 milligrams per kg body weight because of severe inflammation. And within 2 weeks, the patient has responded fairly well. And 1 month, the patient has been absolutely normal. Here it's case of a capillary hemangioma with severe ptosis. That is when the patient, that's how the child was born. This is when the child was brought to me at the 3 months of age. So since there is a severe ptosis obstructing the pupil and we got the CT shows orbital involvement, I started the child with the intralesional triamcinolone to hasten the resolution of the capillary hemangioma so that the pupillary, within 2 weeks, the pupil has been uncovered. And then I put the patient on oral propranolol at a dose of 2 milligrams per kg body weight under the supervision of a pediatrician. This is the serial photos showing how the child has improved when he is within 1 year and how is the child at the age of 3 months. This patient had already developed refractive error and had a squint, convergent squint, which I corrected with surgery, and then the patient had still vision is 6/12. Amblyopia still persisted in spite of all the best efforts. In case where there is a severe ptosis with no total motility restriction and no Bell's phenomenon, we can prescribe crutch spectacles. This is a theoretical option rather than a practical, because by putting a crutch spectacle, you are cutting off the blink reflex, and so the patient cannot tolerate for a long period. So as long as the patient can tolerate, otherwise again he has to remove it, keep it, lift it, and keep it there, and he has to manage like that. So plan of surgery is very simple. Two things are under consideration: amount of ptosis, amount of LPS action. Mild ptosis, that means up to 2 millimeters, where the LPS function is 10 millimeters or more, we do fascicular servet procedure. And if the action is less than 10 millimeters, we do aponeurotic surgery. If the ptosis is more than 2 millimeters, that means mild to severe ptosis. If the LPS action is more than 4 millimeters, that is fair to good levator function, we do levator surgery. And if the LPS action is less than 4 millimeters, we do preferably a bilateral brow suspension. The surgical approaches are, as I said, levator resection, brow suspension, and fascicular servet procedure. Some surgeons do not prefer fascicular servet procedure, because if you do not do properly, there could be a peaking of the lid contour, and that is very difficult to correct. Whereas a levator resection, you can adjust the lid contour deformities, and that is a more forgiving surgery. Anesthesia, local with a Zylcan, bupivacaine or bupivacaine alone, or a general. In general, propofol is preferred, because when I am doing under general anesthesia, when I come up to the adjusting the levator lid height and contour, I request the anesthetist to stop the propofol. Within a couple of minutes, the patient becomes conscious. At that stage, I adjust the lid position and then again continue propofol and complete the surgery. So fascicular servet procedure, you apply 3 marginal sutures and invert the lid, and 3 at the upper part of the tarsus. These are the traction sutures that are applied. The amount of mullerectomy fascicular servet is a tarsomullerectomy. The amount of tarsus we are removing or excising is twice the amount of ptosis. That's why we said that it's a maximum 2 millimeters, so that we can resect 4 millimeters, leaving adequate tarsus for the tarsal support for the lid. That is minimum 4 millimeters. So this is 4 millimeters, that's marked, and the incision is marked, and 2 curved artery forceps are placed such that the apexes face each other, not angled. They face each other, and the tissue is crushed. And then this amount of tarsomular muscle along with the conjunctiva is started excising with a corneal spring scissors. and the excision is continued and it is completed. When the excision is completed, hemostasis is secured. A suture is passed on the medial side from the skin to the inner side, and then the excised Mueller's muscle and the conjunctiva are anchored to the, and the LPS, they are anchored to the tarsus with continuous sutures up and coming up to the lateral side. At the lateral side, again, the suture, sixovical suture, is exteriorized, and then this exteriorized suture is passed through the skin coming to the medial aspect, and then it is tied so that you are exteriorizing the knot. The knot is outside so that the knot and the cottons do not rub against the eyeball and injury it, and the patient is comfortable. This is the preoperative patient, minimal ptosis, 2 mm of ptosis with LPS action, 12 mm, 1 week post-operative. You can see that the ptosis, the lid position is good. Still, there is a little bit of lid edema, and the lid contour, everything is matching. The lid's crease is matching that of the other eye when compared with the preoperative picture in the first picture. This the lid crease distance, and compare it the lid crease distance, that has improved a lot. Levator surgery, I prefer a lid crease incision with anterior lamellar shortening with sparing of Mueller's muscle. We don't do the measured resection. On the table, adjustment is preferred. So the Levator surgery adjustment suit on the tables, the sitting posture is better than the lying posture. Level of eyelid is on the table. The Burke's rule is, it depends on the preoperative levator function. If the levator function is 80 millimeters, the lid stays where it is kept. So if the LPS action is poor, we'll do a little overcorrection. If the LPS action is high, we'll do a 1 or 1.5 millimeters of undercorrection. The role of adjustable sutures is controversial, and it has no how to start this video. So this is the video for the surgery. Just I'll see whether it can be played or not. Video is not playing. Can you? So it's the LPS resection. So the skin incision is marked. Can you stop the volume?
Sir, we are still seeing the presentation video only, sir.
Okay, this video is not. Video is
The
not.
screen in the screen, PowerPoint.
Okay. Because it's doing this played here, will stop.
Yes, sir. Sham.
Sham is looking at.
Now we are able to see, sir.
You are able to see, right?
Yeah,
Okay.
yeah. Now you can go ahead, sir. Yeah.
Cut the volume. Video volume. So the incision is now being marked along the lid crease. Then an infiltration is done with xylocaine, bupropion. This surgery is being done under local anesthesia. I prefer to do all the patients above 15 under local anesthesia. With the RF cautery, the incision is made, and I do usually an anterior lamellar resection. So this is the lower end and the upper. The advantage of RF is that there will be some amount of hemostasis. The skin and the orbicularis oculi along, so that's the anterior lamella being excised. Here you can see this is the orbicularis oculi. Below the orbicularis, the dissection is carried out low, and the dissection is carried out superiorly, and the orbital septum is now being excised. As you are seeing, this is the orbital septum. And once the orbital septum is excised, the levator pre-aponeurotic pad of fat is being seen. This is the big pre-aponeurotic pad of fat. This is the second part of the orbital septum. when once the orbital and the LPS, there is a space between the tarsus and LPS where incision is made, and the tarsus is being, the LPS is being separated from the tarsus with the spring scissors and is being dissected on the right side and on the left side, the medial and lateral sides. And then this LPS is separated from the Miller's muscle, taking into account the superior marginal arcade. The LPS is now, the lateral and medial horns are cut. This is the LPS that has been separated from this. And 40 proline sutures are passed through the LPS muscle, and a horizontal bite is taken at the from the tarsus. Make sure that invert the lead and make sure that it's not gone through and through. And then a horizontal mattress suture is done so that it is the lid height and contour is compared with the other eye. And then the LPS has been excised. The levator is resected now, excess part after the 3 sutures are done. Then lid crease sutures are placed, passing the suture through the skin. Orbicularis take a bite through the LPS, come through the orbicularis skin, and then a frost suture is applied. So through the lower lid, and the lower lid is pulled up and it is attached to the forehead with 5 or 6 small strips of plaster. So this is in short the levator resection procedure that has been edited for half a minute video for want of time. So aponeurotic ptosis. Right. Thank you. So this is the herrings, and this is the patient showing herrings being positive, and LPS function is good. So we did a levator resection. This is a small incision levator surgery that can be done in, especially in aponeurotic case of ptosis. This incision is just 10 millimeters, as you can see here. That is being marked. It's incised, and when once it is inside, you can see that there's a very thin few fibers of the LPS are there. You can see the cornea shining black through that incision. Then the tarsus is exposed. Superior the orbital septum is cut off. Incised. This is the pre-aponeurotic part of it. Behind that, the tarsus has been, the levator palpebral superior has been mobilized, and then that has been anchored through to the tarsus. Invert the tarsus with each bite to make sure that it is not gone through and through. That's very, very important. And then the levator is, LPS is anchored to the tarsus with up to 3 sutures. And this is how the lid on the table, and the small incision is closed with 3 interrupted sutures. Lid crease marking. Pre and post-operative results. Aponeurotic ptosis, pre and post-operative. You can see that the correction is good and movements are also good. This is the pre and post-operative after small incision levator resection. Coming to the brow suspension, the indications are when the ptosis is more, that's moderate to severe, and the LPS action is poor. And also in case of Blepharophimosis syndrome, where the LPS action is always poor. And in Marcus-Gunn ptosis, even the pre-op LPS action is good. When you have excised the LPS muscle to take care of the synkinesis, then LPS action becomes practically 0. So you have to do a brow suspension. Materials could be synthetic, like Gore-Tex, Prolene mesh, Ethibond. I'm using now silicone sutures and not silicone bands. And these problems could be something like granulomas, especially when I'm using a Prolene and Prolene mesh. Or a natural like fascia lata or frontalis sling. So I prefer, when I'm doing a brow suspension, I prefer a bilateral surgery, because this patient, when you do the, whenever you are using the frontalis, then only the lid goes up. When the frontalis is in the normal position, the ptosis will be again coming back. So this is the patient post unilateral surgery where the ptosis is getting corrected only when she is using the brows. When she is not using the brows, normally the ptosis is coming back. So when I do a bilateral brow suspension for such patients, so this is the patient with good action, with good lid position, bilateral, and symmetry in down gaze. For these reasons, I prefer a bilateral brow suspension. If I'm doing a unilateral surgery, I do a Fox pentagon procedure with one central incision. This is severe ptosis with poor levator function. One central incision, two lateral incisions on either side of the brow, and two small incision on either side of the cornea in the lower lid, about 3 millimeters from the lid margin. I'll pass the silicone sling through it and tighten it. And this is the patient 1 week post-operative with, this is the pre-op and this is the post-op with RO sling. Complicated conjunctival ptosis, converted it to a simple ptosis first and then perform the ptosis correction. In case of elevator palsy, it's NAPS procedure or inferior rectus recession. In Marcus-Gunn ptosis, excision of levator palpebrae superioris and bilateral brow suspension. In Blepharophimosis syndrome, first correct the telecanthus, increase the horizontal width by doing a lateral canthotomy also, and then bilateral brow suspension. Congenital ptosis with double elevator palsy, absent or poor Bell's phenomenon, ptosis correction can lead to exposure keratopathy if you do not restore the Bell's phenomenon. Hence, restore Bell's phenomenon first, do FDT. If the force reduction test is negative, we do strengthen the superior rectus by doing an APS procedure. If FDT is positive, it's a tight inferior rectus, we do inferior rectus recession. If vertical deviation is severe, more than 20 prism diopters, we have to do both procedures at an interval of 3 to 4 months between the procedures. In NAPS procedure, we do a 360 degrees peritomy, identify the lateral rectus, pass a suture and disinsert, identify the medial rectus, pass a suture and disinsert, and then identify the superior rectus muscle. And now the medial rectus muscle and the lateral rectus muscle are sutured on either side of superior rectus. This is called NAPS procedure. So this is a patient with severe congenital ptosis with DEP, double elevator palsy, pre and post-operative after NAPS and brows procedure. This is again patient with DEP. You can see that there is no elevation and there is no Bell's phenomenon. So she underwent surgery after NAPS procedure. So she had a lid retraction also. So what we did is, we did a NAPS procedure. Now the elevation is normal, Bell's phenomenon is restored. I did a fastener servet procedure because the surgery ptosis is not very severe, and the exercise tarsus I use to correct the lower lid retraction. And this is how the patient on the table, first post-operative day after surgery. Marcus-Gunn ptosis, if synkinesis is minimal, ignore it, treat it like a simple ptosis. If synkinesis is significant, excise the levator palpebrae superioris and do a brow suspension. If it is associated with the DEP, first correct DEP and later the synkinetic ptosis. This is the patient with Marcus-Gunn ptosis, with elevator palsy, post levator correction of DEP, post levator excision. This is how the patient, and you can see that the synkinesis is corrected and the eyelid position is normal, ptosis is corrected, and patient is looking good. Blepharophimosis syndrome, you measure the inner intercanthal distance should be half of the interpupillary distance. Accordingly, move both the inner canthus by doing a Z plus or Viviplasty. and do a lateral canthotomy and then do a bilateral brow suspension as in this patient. For example, if the IPD is 60 millimeters, the inner intercanthal distance is 40 millimeters. That means it should be, the inner intercanthal distance should be half of IPD. That means 30 millimeters. So it is 10 millimeters more. So on each side, you reduce by 5 millimeters. You move the medial canthus by 5 millimeters. If the horizontal width is 20 millimeters, by moving it by 5 millimeters inner canthal distance, the horizontal width is becoming 25 millimeters. But what should be normal? 30 millimeters. So the lateral canthus, I am moving out by 5 millimeters so that it becomes 30 millimeters. 20 millimeters original, 5 millimeters by moving the medial canthal, 5 millimeters by moving the lateral canthus. And then I'll do bilateral brow suspension. This is pre-op and that's post-op. And these are the measurements that I'm talking of. And this is another patient of Blepharophimosis, pre-op and post-op, after correcting the telecanthus, increasing the lateral canthus, and bilateral brow suspension with autogenous fascial end. So the take-home messages are, in down gaze, there will be lid lag in congenital ptosis and further narrowing of palpebral aperture in acquired ptosis. Number two, amblyopia is fairly common in congenital ptosis, and the important cause is anisometropic astigmatism. So, even if any child is brought with congenital ptosis, look for anisometropic astigmatism. If it is present, refer the patient for immediate ptosis correction. Otherwise, we'll postpone the surgery till 4 or 5 years. Ice bag test is a simple test for diagnosis of myasthenia. Significant association is between DEP and Marcus-Gunn ptosis is present. In complicated congenital ptosis, first correct the associated factor and then correct ptosis. The types of surgery for ptosis correction depends, as I said, on amount of ptosis and levator function the patient has. Thank you all for your attention. Thank you.
Thank you, sir. Thank you so much for comprehensively covering all the evaluation techniques and also surgical techniques for ptosis, sir. Sham, do you have any questions in the website?
No, sir, not as of now.
Okay, okay, right.
So,
So the next is lid tumors and principles of lid construction, sir. Next week.
lid reconstructions we'll do it.
Yes, sir.
As
Yes,
per
sir.
the order.
Yes.
Whatever is in that order, we'll do as per that. Okay.
Yes, sir. Yes, sir. Thank you, sir. Thank you.
Thank you so much.
Yeah. Yeah.
Thank
Good
you.
night, sir. Good night.
Good night.